Hello, everybody, and welcome to this afternoon's session on SMA. I can see people coming through from the waiting room, so we'll just start shortly when more people have come through. Thank you. Good afternoon to those joining us still. We're just waiting for people to come through from the waiting room, and then we'll begin the session. Thank you so much for joining us. Great. I can see our numbers leveling off for the waiting room, so I'll start us off. So yeah, thank you so much for joining us this afternoon. I'm Rob Burley. I'm Director of Care, Communications and Support at Muscular Dystrophy UK, and welcome to this afternoon's Muscle Matters online seminar on spinal muscular atrophy, focusing on adults. The Muscles Matter seminars has become a regular feature in our calendar at MDUK, and we're hoping that this year they'll run alongside some live events when we can host those as well, but we're definitely going to keep them going because they've been a really sort of popular part of our calendar. Throughout the series, we're also, don't forget that our helpline remains available and our info line. So if you need any help or support, you can contact us through 0800 652 6352, or you can email info@musculardystrophyuk.org. We're really grateful to be joined by an expert panel covering a broad range of expertise on spinal muscular atrophy this afternoon, and we're also really grateful to have the support of our sponsors. We're splitting the session into two parts, and we'll begin by looking at research and treatments before then exploring living with and managing the condition. And before we begin, a quick note on how you can ask questions or make comments throughout the session. We've had some advanced questions and we'll seek to cover those later on. We'd also like to incorporate some live input, and to do this we'll be using the Q&A function. So please type your question or comment and we will then feed them into the discussion. To help us manage the technical side of the event, we won't be calling on questioners to ask their questions directly. Any questions we don't manage to cover or that we don't know the answers to, we'll seek to answer through our website afterwards, or we'll get in touch with you directly. And finally, a reminder that we're recording this session and it will be made available over the next few days. And the session on pediatric SMA is available already on our YouTube page, so we'll share the link with that as well. So to start us off this afternoon, I'm delighted to hand over to my colleague, Dr. Kate Adcock, who will introduce the research section of this afternoon. Kate, over to you.
Thank you very much, Rob, and good afternoon, everyone. I'm delighted to be able to introduce such a great panel this afternoon who'll be talking about research and treatments. Firstly, you'll be hearing from Dr. Channa Humaduma, who is a consultant neurologist who's based in Sheffield. He has specialist interest in a broad spectrum of neuromuscular disorders, including spinal muscular atrophy, but also myasthenia gravis, various muscular dystrophies, neuropathies, hereditary spastic paraparesis, and motor neuron disease. He leads a number of clinical trials in several neuromuscular disorders at the Sheffield Teaching Hospitals Foundation Trust. After he's spoken, there'll be an opportunity for us to discuss a number of questions and questions in the answer session, and he'll be joined by colleagues from NICE and the SMA registry. So he'll be joined by Charlotte B, who is a program manager within the managed access team at NICE and is responsible for the day-to-day monitoring of data collection arrangements for the treatments that are in managed access. And Mariam Udin is a senior manager within the same team at NICE and is responsible for overseeing that data collection and the arrangements for the treatments that are in managed access. And together, Charlotte and Mariam help to ensure that NICE has the information it needs to update its guidance at the end of a period of managed access. This includes engaging with patient organisations, companies, clinicians and commissioners, and you'll hear a little bit more about that later on. And finally, for this session, I'm delighted to be able to introduce you to Lindsay Murphy, who coordinates the UK SMA Patient Registry and the Global FKRP Registry at the John Walton Muscular Dystrophy Research Centre at Newcastle University. She's part of the team working on the natural history study, Adult SMA Reach, and is working to implement the collection of patient-reported outcome measures, also known as PROMs, to the patient registry. So I'm hand over to Channa for you to talk us through your slides, please. Thank you.
Thank you, Kate. Thank you very much for that introduction. Let me try to share my screen. could you see some of
Yep.
my slides?
We can.
I'm using two screens. Just make sure that you can see. Can you see my presentation?
Yeah, it's in presentation mode now. Yep.
Marvelous. Good afternoon, everyone, and thank you, MDUK, for inviting us to give an update on what's happening in terms of research in adult SMA cohort. I'm afraid that there isn't much happening, but I will try to draw from some of the recently completed research work published already in literature, and then also some of the data that we are expecting from duly concluded studies. So these are my disclosures for the talk. And we all know how SMA is affecting both children and adults, but I would like to give you a little brief introduction to the genetics of spinal muscular atrophy. As you know, SMA is the commonest inherited pediatric muscle and nerve and motor neuron affecting disorder, and this condition causes significant morbidity and mortality for both young people, as well as significant morbidity to the adults who are affected by spinal muscular atrophy. And this is predominantly due to the mutation or variation in a gene called survival of motor neuron 1 gene. What happens is that in majority of the patients, this gene is deleted. You inherit two copies from mother and the father, and the deletion of both these copies is the commonest cause of the spinal muscular atrophy. There is a similar gene called survival of motor neuron 2 gene, which is very much similar to the SMN1 gene. However, it misses out its exon 7. If you imagine that this gene is like a train with 9 compartments, the 7th compartment is missed out on SMN2 gene. If you look at this carefully, the SMN2 gene has this exon 7, as I said, that is missed out during the process of fitting the coaches of a train together, or what we call transcription. And in that process, this exon 7, the coach 7, is excluded. So it forms a shorter train without the exon 7 that is unstable, and the body gets rid of it. Therefore, it cannot compensate for the loss of SMN1 gene. However, in about 10 to 20% of the times, this error that excludes the coach number 7 includes it and forms the full-length SMN protein. But this is not good enough to rescue the loss of SMN1. And this is what then leads to a spinal muscular atrophy. We know that there are several types of spinal muscular atrophy: type 0, type 1, 2, 3, and 4. And basically, this is based upon how severe the symptoms at onset and at what age the symptoms come on. If, for example, a child is unable to sit up and then their symptoms start within the first 6 months, then they are said to have type 1, which is a severe form of spinal muscular atrophy. Type 2 patients are those who are able to sit, but they are never able to walk or stand. And type 3 patients are those who develop symptoms after 18 months of age, and they are able to walk, stand independently. And this classification has come into debate more recently, because this classification first came up when we wanted to characterize our patients to help recruitment to clinical studies and monitor them and to allocate resources at the time. But now we have disease-modifying treatments which have become available for spinal muscular atrophy patients, and to then make these treatments available to these patients based upon an arbitrary classification seemed very unfair. So therefore, people are contemplating whether we should look at this disease cohort as those who are able to sit and unable to sit, and those who are able to walk. In other words, called non-sitters, sitters, and walkers. bearing this in mind, we know that it is quite obvious in childhood that the patients do deteriorate fairly rapidly, and this is well monitored because they were seen in clinics very regularly. But in adult neuromuscular clinics, when the patients have transitioned from a pediatric setting, the patients were monitored, but not as regularly as they were seen in pediatric clinics. So when they came to our clinics once every 12 months or 6 months, they seemed stable. However, we know from natural history data that you can see here, when you look at ambulation against the disease duration for those type 3 patients, that they all continue to deteriorate with time. It's a matter of following them up. And here the graph on the right hand side shows both type 2 and 3 patients also deteriorate as you continue to monitor them over second, third, fourth decade of their lives. And this is by monitoring the motor function called the Hammersmith motor score extended. So more recently, Kurati et al. Also followed up a large cohort of type 3 patients, and they too, if you can see here, when you look at the Hammersmith function motor score extended, or the Hammersmith score, that they continue to deteriorate with time. And they also looked at whether there was an association between, if you had more SMN2 copy numbers, whether there would be a difference in how you progress, but they didn't really find a big difference with the SMN2 copy number, because we know that if the SMN2 copy number is high, then perhaps you produce a little bit more full-length SMN protein, which might rescue the phenotype a bit. However, it was also noted that not all adult SMA patients had SMN2 copy number assessed. The point is that spinal muscular atrophy is a progressive disease, and patients do deteriorate with time, although they seem to be stable. And one of the things that affected their close monitoring and regular follow-ups was the lack of effective treatment. But this all changed since the India and Cherish clinical trials came about, studying the effect of Nusinerson, one of the first drugs that became available to modify how the SMN2 gene is spliced and how that can be affected. So we know that these studies showed significant benefit to the children who received Nusinerson. Over 50% of the patients in both study groups showed improvement in motor function compared to their placebo control. And this is well-established evidence now. And this is how Nusinerson works. If I may remind you how the SMN2 gene is different to SMN1 in that exon 7 is spliced out, or this coach is removed. What the Nusinerson does is that it binds to the mechanism near the exon 7 and makes it included. And this by including exon 7, it produces the full-length SMN2 transcript, or what we call the mRNA, and that goes on to produce the full-length SMN protein. And this provides some degree of protection. Now, pediatric data is well established, and the India and Cherish did not really study the adult cohorts of patients. But we know the benefit of Nusinerson in the early onset SMA age groups. Therefore, it has been widely used now in adult populations. So Hagenegger et al. Is from Germany. They studied 173 patients of adult SMA patients, and they studied the patients over 14 months across 10 centers. I won't bore you with details, but their primary endpoint was to see whether what happens to their motor score in terms of assessing using the Hammersmith score. And then they also looked at the upper limb strength by using the RULM score, revised upper limb module. And they also looked at the endurance by using 6-minute walk test. They also looked at what were the differences between type 2 and 3 patients, and were there any differences between non-ambulant and ambulant patients. This is because this is a large group of patients. It was very helpful for us to draw from their experience. And when you look at time points 6, 10, and 14 months, their average age was 36, 37, and 33. The majority of the patients you can see are type 3 patients, which were about 2/3, and 1/3 were type 2 patients. And again, about 2/3 of their cohort were non-ambulant. They were wheelchair bound, and about 1/4, that means 25% of the patients also had spinal procedures, making lumbar punctures not that easy. And I've just drawn out some key motor findings. If you look at the Hammersmith Motor Score, which is their primary endpoint, they showed that even at 6 months, there was a benefit. Now, let me take you through these graphs. So the leftmost panel is at 6 months, the Hammersmith Motor Score against the individual patients, and how they have either they have improved is from 0 to 20 points, and whether they have deteriorated is from 0 to -15 points. And those who are above the x-axis are those who have improved, and the flat line indicates those who have stayed stable, and ones who are below the x-axis are those who have deteriorated or who have lost points by 6 months. But you can see that as 10 months and 14 months reached, and more patients were improving in terms of their motor function score. At 14 months, only 57 had completed 14 months. So when you analyze them, 55 of them have either improved or stayed stable. Only 2 patients deteriorated. And this difference in improvement is quite significant. And we say that if there are 3 or more point improvement in Hammersmith score, that is clinically significant. Even 1 point can be very significant to some SMA patients. And this was very statistically significant. In a condition that is progressively deteriorating, to be able to achieve stability is the key, and an improvement, I would say, is a welcome bonus. And then Nusinerson is not the only treatment now we have in our armamentarium. We are lucky to have a second drug, which is the Risdiplam, and this is an oral solution, as you know, this works kind of the similar way by, it's a small molecule, by acting on the mechanism by which SMN2 gene excludes exon 7. It binds to these mechanisms and makes sure that the exon 7 is again included. The difference is that this is an oral solution, and therefore you don't need an intrathecal injection. The data for this comes from various clinical trials. The Firefish and Sunfish are the main studies. And what is relevant to the adult population is the Sunfish study, because it included patients between age 2 and 25 years. And it also had type 2 SMA patients and non-ambulant type 3. So quite a heterogeneous group of patients. And their primary endpoint was looking at an improvement in motor function in a score called Motor Function Measure 32. It's a 32-point scale at 12 months. And now we have, in fact, we might be able to obtain 36-month data as well. But if you look at the 12-month and 24-month data, you could see that orange line are those patients who received Risdiplam, as opposed to the gray line, which are those who were on the placebo arm. At 12 months, there was the separation between the 2 lines, and then you could see that the improvements gained by the Risdiplam group and those who then went on to the Risdiplam group continued to maintain an improvement in the motor function score. Now, when you compare that with the natural history, so natural history SMA studies group, for those who are type 2 SMA and non-ambulant type 3 SMA patients, the natural history shows that they will continue to deteriorate. But compared to that, you could see that in the orange line stays the gains have been maintained, and which is quite encouraging to note. When you look at the side effect profile, why this is important is Risdiplam is relatively new to us. Therefore, we need to gain more information and understanding of the side effects associated with this drug. And we could see that upper respiratory tract infections and nasopharyngitis were commoner in Risdiplam group compared to the placebo group. And headache and diarrhea were the other two main side effects noted. And compared to 12 months, by 24 months, you could see that the frequency of these events has reduced. That is a bit encouraging. So in summary, we have noticed that Risdiplam is beneficial and the gains are maintained even at 24 months. And the side effects are mainly nasopharyngitis, upper respiratory tract infections, diarrhea, but these frequencies have reduced by 24 months. So what are the new studies that adult patients can access in spinal muscular atrophy? That there aren't many, certainly there aren't any in the UK. So SMA Reach, the registry for the adult patients is the main, I think, the study program that we have. And this is, I'm sure Lindsay will expand on this a bit more. Newcastle leads on this, and all the SMA treating centers take part in it. It forms a very important part in the both managed access agreements for Nusinerson and Risdiplam, because this will help us monitor how our patients are doing on these two new drugs that we don't have much evidence in the UK population. And at the end of managed access agreement, we will be able to inform NICE and NHS England on how we have done, our patient cohorts have done, and whether they might take on the licensing and approving as standard care thereafter. There are a few other studies, and there are some molecules which are quite center of attention currently, and hopefully these might be applicable to adult patients. The Manatee trial is a phase 2/3 a clinical trial that is planned to start early this year, and unfortunately this is mainly for children between, I think, up to about age 10 who are SMA type 2 and non-ambulant type 3 patients. UK has recruitment centers. I think Oxford, Birmingham, and London, Gosh, are centers who will recruit patients to this center, to this study. This is about using anti-myostatin antibody along with the Risdiplam. So Risdiplam, you know how it works. Anti-myostatin antibody is an antibody that targets myostatin. Myostatin is an important protein that regulates skeletal muscle size and it controls the growth. So by inhibiting or blocking this myostatin protein, one expects increase in muscle growth in size and perhaps also help reduce fatigue and increase strength. So that's the idea of this study. And similar study uses another drug called apitegromab, which is a phase 3 clinical trial called Sapphire. It is planned by Scholar Rock. It's a global study. Now, the design is interesting in that this molecule is accessible to anyone who's on either Nusinerson or Risdiplam as a combinatorial treatment. Again, this is a specialized antibody that blocks the myostatin. So they plan to recruit 156 patients aged 2 to 12 and 48 patients aged 13 to 21. So there is a component of adult patients who could access this treatment. I'm not aware of whether there are any UK sites for this study planned yet. So Risdiplam is a phase 2 hypothesis generating study in that they didn't define primary endpoints. So this is a drug that improves skeletal muscle function. What it does is that it increases the sensitivity of the muscles to calcium, so that they make the muscles more, they improve the muscle contraction and the strength of it. They studied both type 2, 3, and 4 patients who are older than 12 years of age. And it's a relatively short study where they looked at endpoints at 4 weeks and 8 weeks since the treatment initiation. The differences were they looked at 2 different doses. I might draw your attention to one of the 8 outcome measures they use. They use the mean expiratory pressure, which came strongly positive in terms of in favor of the drug, but none of the other outcome measures were significant for the lower dose of the drug at 8 weeks. But when you look at the higher dose of the drug, the mean expiratory pressure as well as the 6-minute walk test showed some promise of in favor of the drug, but none of the others stood out, including the muscle mega score, which is the subscore of muscle strength, showed actually a deterioration. But when you look at the 6-minute walk test, you could see that in this graph, the patient who received the higher dose of the drug maintained a good degree of muscle function in terms of 6-minute walk test, which is an endurance test. There are many other studies which have been completed or are being completed, but the results have not been published yet. You can categorize this broadly into 3 main categories. In red are those drugs which are working on the neuromuscular junction. So there's a lot of evidence to say that neuromuscular junction is dysfunctional in spinal muscular atrophy patients. Therefore, they have drawn from our experience in managing, for example, myasthenia gravis patients. Myasthenia gravis is a condition, it's an autoimmune condition that affects the neuromuscular junction. So neuromuscular junction is where the motor nerve ends on the muscle, what we call a muscle end plate. There is no direct connection. There is a little bit of a space that is between the nerve ending and the muscle, where the muscle begins. That is called the neuromuscular junction. So how the signal gets from the nerve to the muscle is by a release of neurochemical called acetylcholine. Now, to release this acetylcholine, you need an increase in calcium signal within the nerve ending. So amifampridine is a drug that increases this calcium signal, and that increases the acetylcholine secretion. So pyridostigmine is a drug again used in is a drug that is used in myasthenia gravis, where there is excess acetylcholine gets mocked up by an enzyme, and pyridostigmine blocks that enzyme, and thereby increases the acetylcholine availability at the neuromuscular junction. And in myasthenia gravis, that increases the muscle strength and reduces the fatigability. So the same theory has been used in spinal muscular atrophy, but the clinical trial for amifampridine was conducted in 2015 and another study in 2020, but both are not published. And pyridostigmine study is a monocenter. One center tried this drug, and they published the protocol, but they haven't published the results yet. The second category of studies are based upon increasing the SMN protein levels. For example, salbutamol is said to reduce the degradation of SMN protein, and also there are some studies which shows that it increases the SMN2 gene full-length transcript, and there are also other studies which shows that it increases the muscle strength in the normal people as well. And there are studies in another condition called facioscapulohumeral muscular dystrophy, where they showed there is increase in muscle strength, and there are conditions like congenital myasthenia where salbutamol was shown to be shown to increase muscle strength. So various theories have come into place to study salbutamol. It has been shown in pilot studies in pediatric patients that pediatric patients with spinal muscular atrophy, that it increases muscle strength, and some studies show that it increases respiratory function, but the numbers are very small. Similarly, valproic acid is also, valproic acid is an anti-epileptic medication, which is thought to regulate the spinal SMN protein levels. And in animal models, it showed an increase in survival and strength. But in human studies, it was not effective. And particularly in children, when they use valproic acid, they need to treat that with acyl carnitine, because valproic acid reduces carnitine in children. And that's why the acyl carnitine comes as a molecule used in SMA. Hydroxyurea is, the study has not continued because it's toxic and there was no clear benefit. So it had to be very cautious when you're using the study again, trial again. Riluzole is a drug that is used in motor neuron disease. It helps reduce hyperexcitability, which is thought to be a cause of motor neuronal injury and toxicity. So there are 200 plus clinical trials in the clinicaltrials.gov website. One can access all the latest clinical trials that's happening and recruiting across the world. And these are the ones that I have been able to filter out as remotely relevant to us. Well, thank you very much. In summary, I'm sorry to disappoint you that there are no active clinical trials, but I think myostatin studies in pediatric population is interesting to watch, because it might have implications to adult population. And also, it might be useful for us to await the outcomes of the jewelfish Roche clinical trial, which is currently ongoing, and results are expected, I think, end of this year or early next year. I'm very happy to answer any questions if you have.
Thank you so much, Channa. That was really fascinating. I have a couple of questions that I want to just follow up with you, and we've had one come through the question and answers, but if anyone else has any questions, please do type them into the Q&A function at the bottom of the screen on your Zoom screen. One of the questions is, you mentioned a trial called Sunfish, and also recently then the rainbow fish, there's jewelfish and firefish, I believe is all the name of the trials. Do you know why they've got such interesting names? Is that anything you've heard about?
I'm trying to share a slide. Can you see anything right now?
No, it's gone back to, for me, it's just gone back to the panel view.
Okay, I'll stop sharing. I was trying to show you a slide. I was trying to show you a slide of various fish clinical trials. I'm not entirely sure why they have selected fish studies. There might be a very good reason for this. I do not know whether, I think I saw my colleague Maria is online as well, whether Maria knows a good explanation for it.
No, I'm afraid I don't. We had asked that question as well, but I don't know the answer.
I think that the names that clinical pharmaceutical companies come up for the names of their clinical trials is often quite fascinating, and similarly how they name their drugs, which often are incredibly difficult to actually articulate, I think is quite cruel in some respects, how difficult they make them to say. So okay, well thank you, but I think that's a great question, because it's something we just sort of take for granted and don't necessarily think why are things called why they're called. And just going back to the studies that you mentioned towards the end there, Channa, where you've got things like the neuromuscular junction drugs that are being tested, do you envisage that these would be treatments that would be taken in combination with other drugs. So if somebody, for example, is already taking Risdiplam, also called Evrysdi, or the other drug Nusinerson or Spinraza, do you think that that would be something that they would take as well, or do you think it would be an either or?
I think we have strong evidence currently for Risdiplam and Nusinerson. So without a doubt, we should give priority for those two drugs. And if we were to use any of the other drugs, we need to have clear clinical trial-based evidence before we could recommend such treatments. Now, of course, it is well and good for us to say this in the developed world, but what about the SMA patients in developing countries who cannot access very expensive treatments? And for those patients, a pyridostigmine and amphetamine is a new version of what we used to call a 2,3,4-diaminopyridine, which is cheaper in the developing world to access. So it is difficult for me to say, no, you have to be absolutely go by evidence, but that is what we should advocate, to use evidence-based medicine. But if convincing evidence can be borne out from those clinical trials, they have massive implications for economies who can't afford expensive drugs. If the evidence is supportive of pyridostigmine and such like drugs, then I guess it might be it could be used in combination, but that is hypothetical in the absence of evidence.
Thank you. And you also talked about the some of the side effects of Risdiplam that kind of go down over the sort of 2 years. So 24 months, they were actually no different from the placebo, or very, very minor. Do you have any ideas as to why that might be?
One of the reasons that we have noticed that in our cohort as well, we have now over 20 patients with Risdiplam, and gastrointestinal side effects were reported by some, and in fact, one patient had to stop the drug completely after having tried several stopping and starting methods. And the other patients who have had the gastrointestinal side effects, they adjusted their drug along with their food, and the symptoms disappeared. It could be that I think the theory is some people might be intolerant to fructose, and there might be fructose within the Risdiplam, and that may be that they are reacting to it. The other explanation is common sense, which is not all patients develop side effects, and not all side effects, when they develop, stay for long. They get used to it, and then people get around and get around the side effects, and their bodies get used to it.
Okay, thank you. That's interesting.
And partly there might be when we all start a new drug, we constantly ask the patient, do you have any side effects? Is there anything is the matter? Because we want to be able to report anything that is new and unknown. And that could lead to perhaps increase in reporting of side effects or detection of that. And then as we all get used to it, and then patients say, well, that's fine. I thought it was related, but it's not.
I see. Thank you. And the question that sort of we thought of in advance was about how, if people feel that they're eligible for a treatment, who should they speak to access a treatment? So the ones that are available already.
Most SMA patients will be known to a neuromuscular center. However, having said that, about 4 of our patients had over the years lost contact with us, and they got in touch with us thanks to the SMA, the charity, the patient organizations. So similarly, if you do not have access to a neuromuscular center, if you do not know who that could be, it would be best to talk to either your GP or if you know your SMA patient organization representative, they might be the best people to talk to, and then they might put you in touch. Several such patients were put back in touch with us by the patient organization.
Brilliant, super, thank you. And then moving on to our other colleagues, so Charlotte and Mariam, can you just explain, we've heard a little bit about the Risdiplam and Nusinerson, or Risdi and Spinraza as they're known. These are available at the moment certainly in England through something called a managed access scheme. Could you just explain a little bit about what that means and what that means for patients as well?
Thanks, Kate. So a managed access agreement is, I guess you could say, it's like a contract. And when there's a treatment that's been approved by the MHRA, but there's still uncertainties about cost effectiveness for the NHS and about the clinical effectiveness about the treatment, it enters NICE's managed access. So what happens in managed access is that the treatment is essentially given some time to be able to collect more data, whether that's clinical trial data or real world evidence or both. So within a managed access agreement, patients are signed up to the treatment by their clinicians, and their data would then be used by the company or the registry that the companies contracted to analyse the data as the managed access agreement goes on. The data that is collected is routinely monitored for quantity and quality assurance purposes by NICE and NHSE colleagues. It's all confidential and is regularly reviewed also by a clinical panel and clinical experts. So the whole point of a managed access agreement is hopefully if the treatment is effective and it is cost effective and the data that is collected addresses all the uncertainties outlined in the beginning, it should have a positive recommendation, and then patients should be able to access that treatment just on an ongoing basis. If in the unfortunate event that the data either isn't enough or it doesn't address the uncertainties in the way that we would have hoped, then the treatment stops being available for new patients, but there tends to be an agreement that patients already on it can continue to be on it as long as they and their clinicians agree.
Thank you, thank you. And you talked there about data and data collection and real world evidence, which leads me on to you, Lindsay, about thinking about the patient reported outcomes that I mentioned, or PROMs, which I love that name, we mentioned earlier on. Maybe could you talk a little bit about how patients and people can get involved in helping collect some of that data by interacting with the registry, what the registry is, and yeah, maybe a bit about that.
Of course. Well, more and more it's being recognised the importance of the patient perception of their condition, whether they are receiving treatment or whether they aren't at all. And so in order to collect this perception and observation from a patient, we are implementing the collection of patient-reported outcome measures in the patient registry. These patient-reported outcome measures are basically trying to collect information about the patient's perception of their quality of life and the impact of any treatment, if they're receiving it, on their activities, normal activities of daily living. The patient registry has been established for a good 10 years or more, and we are you can access this online. We through our website. We collect patients registered themselves in the patient registry, and they can then, once they are informed about the registry, provide their consent for a collection of their data. They're then able to complete questionnaires within the registry, and in particular some of these will be collecting the PROMs data. These are short questionnaires, and this information with the patient's consent will be shared with the SMA REACH clinical databases, and they will be able to align the patient data from the PROMs with clinical data collected within the SMA REACH databases, anonymize it, and then this data can then be put into a report and used for review by regulatory authorities to help understand the impact of treatments.
Fantastic, thank you. And it's important to highlight that, as you said there, that the data is anonymous, so people can't come kind of digging through the data and work out who has submitted it. And similarly, the researchers and anyone from industry wouldn't be able to see. So I think that's great. Thank you. I'm very mindful of time, so I hope that you all remain on the call. It's been very great to hear from you so far. Thank you all so much. So thank you to Channa, to Mariam, and Lindsay, and to Charlotte. If I hand back to you, Rob, I'm sure you'll be able to bring those guys back into the conversation should there be questions for them in the next part. So thank you.
Thanks, Kate. Yeah, thanks everybody. That was a fascinating session on research. So yeah, we're going to move now to talking about living with SMA. So as well as Channa and others staying with us, I'm delighted to welcome 3 more panelists. After I've introduced them, I'll invite each of them to say a few words about their experience and their role in supporting adults with spinal muscular atrophy, and then we'll move into questions and discussion. So do keep using the Q&A function throughout. So I'm really pleased to welcome Dr. Maria Farrugia, who graduated in medicine and surgery from the University of Malta in 1995. She trained in neuromuscular disorders at the Muscle and Nerve Centre in Oxford and has been a consultant neurologist at the Queen Elizabeth University Hospital, NHS Greater Glasgow and Clyde since 2007. Also joined by Katie Nevin, who is a clinical specialist physiotherapist in neuromuscular disorders. And Katie joined the neuromuscular team in Sheffield in 2015. And I'll ask Katie to explain the role of a specialist physiotherapist shortly. But essentially, she assists patients with long-term conditions and helping them to self-manage and understand their condition as well. And then we're joined by Liz Ryburn, who's the support team manager at SMA UK and has been with the organisation since May 2011. The charity has been providing information and support and funding and supporting research-related initiatives since 1985. And Liz has a professional background in social work and disability rights, and we're very fortunate to work very closely with Liz and her team, both on issues such as access to treatment, some of the treatments that Channa was discussing, and also other issues affecting people living with SMA. So thank you very much for joining us. Maria, could I come to you first, just to kind of give us a view of the team that works under you and the role of the consultant in providing care and support for people living with SMA, and the kind of elements of a team that you would manage?
Oh, thanks, Rob, and thanks for having me. It's been a wonderful meeting so far. Yes, so in any neuromuscular case, you do require to work with a team. It's not just the consultant who looks after the patient, but you require input from a neuromuscular nurse if the center has the availability of a nurse. And largely, physiotherapists are fundamental for supporting not only the patient, but also the consultant, and in order to establish progress of the patient, particularly now in SMA, so many exciting things are happening. We've got treatments, and it will also be important and pertinent to actually follow up and actually measure the response to treatment. So physiotherapists are fundamental to the team. And of course, other people are important as part of the team. We have occupational therapists that need to assess a patient's needs from time to time. If the patient develops swallowing difficulties, the speech and language therapists are also crucial in assessing swallow and giving advice on dietary textures. Care advisors, very important, not only to the patient, but also to the family that live with the patient in supporting that individual. There will be other individuals that are also part of the team, like advocacy officers, for instance, people that are helping with the employment aspects. There are some patients who are in education, they may require support in their education place. And then, of course, the respiratory muscle team, very important for SMA, very important for a lot of other neuromuscular conditions, and in some other neuromuscular conditions, not only SMA, the cardiologists will be also an important part of the team. So that's really, in a nutshell, the team that actually supports the clinician and the patient throughout their journey together.
Thank you. That was a very good, succinct explanation of everybody that's involved. Thank you so much. And Katie, we've sort of hear a lot of these sessions about the importance of physiotherapy. So could you maybe just explain why specialist physiotherapy for a condition like SMA is so important and the kind of key principles that you follow?
Yeah, definitely. Hi, everybody. Thanks for having me. So I think we've got to bear in mind that SMA is a rarer condition in the wider kind of neurological world. So we have just got to think about what other therapists or teams might have ever come in contact with someone with SMA. You might have seen someone in the community or a smaller team out of the bigger neuromuscular centres, and you might be the only person with SMA they've ever seen. So I think it's making sure that you link in with a specialist team is really important, so you get that specialist advice on how to manage your condition. And then definitely what I do is link in with the local community teams, because often we cover such a large patch. So linking in and providing that education and support to the local community teams is really important. So ensuring that communication comes in and out of the specialist neuro teams.
Brilliant. Thank you so much. And Liz, it'd be great to hear a bit from you just about the role that SMA UK sort of plays and the support you're able to provide people, and also just some of the themes that maybe come through the support services that you run at SMA UK.
Oh, thanks, Rob, and thank you for inviting me along as well. I think one of the big things we've been working on for the last 4 or 5 years is access to treatments, and we've partnered a lot with MDUK and clinicians on that. I think we're feeling we are over the hump. We hope we're over the hump, but I mean, there's more to come when we go back to NICE at the end of these managed access agreements. But it was timely last autumn for us to check in with the SMA community and say, what do you want from SMA UK now? What should we be doing? And so we put out a survey and we got good feedback about what we're doing. Very much saying we do want the information you're putting out there. We want information about living with SMA. And we have a whole section on our website about that. And that's about leisure, work, education, and it's informed by people from the community giving us their ideas and their tips. And we put that on the website. And then we've got an information area, which is really for people who are recently diagnosed, which is information about SMA and managing the condition. Obviously not in the depth that the clinical teams are talking about, but again, it's tips and ideas from the community that we put together into information sheets. And the community said they really still wanted us to deliver an individualized support service. So we do that. People contact us by email or phone or Facebook. And we have to remember adult community is very switched on, very well connected, but all of us at times get stuck. So we might be contacted about difficulties accessing treatment or a review of a care package. How do I best present my argument? And we've got a small team of very experienced workers who are always happy to help. Plus, we've got the network of the adult community network, a questions network, where we can put things out to the community for their advice as well. Community said they wanted more podcasts and videos. You may have seen some of those coming out on social media. And a lot of the podcasts are people just talking about living with SMA and a number of, any topic that they might want to consider. And some of those are really, really interesting and worth listening to. We've got one coming up this Friday, which is 3 people talking about personal assistance. And that kind of links in with the other thing the community wants from us and MDUK and everyone is advocacy. And we know that personal assistance and care and support is a big issue, recruitment and retention. So we're hoping that this podcast will be a trigger to start pushing this further up the agenda. What else? I think, and then so talking about advocacy, we really listened to that, and we've now recruited somebody to take on the role of advocacy lead. That's Portia Thorman. Some of you may have met her already. And again, linking in a lot with MDUK on that. What should we be jointly working on? Because we're a small organisation, and a lot of the topics that we hear from the community are about living with disability and the social problems, the social barriers to access. So that's something we need to work with alliances on. And then finally, people said, if possible, they would like to meet face to face again. So we're going to see how that goes. We've got some picnics organised in different regions across the country. They're happening in the summer, so let's hope. But nothing too ambitious at the moment, but yes, do look out for those. And so everything's on our website, smauk.org.uk.
Thanks, Liz. And yeah, just I think to put on record how much we value and enjoy working with you in the team. I think it's really important that as charities we sort of collaborate well. So it's great to have you with us. So thank you. We had a question. We had a couple of questions in advance, and the first one I'm going to throw to UKT, which was the question was: could physiotherapy help someone with SMA kind of maintain sort of strength? And I guess, but it'd be great to get your view on that, but also just the wider sense of kind of what happens in an SMA clinic with a physio for someone with SMA.
Yeah, thanks, Rob. So if you come into the SMA clinic, hopefully you'll get to see a physiotherapist at your local clinic. And what we do, not only are we doing all the assessments and the outcome measures for people taking these new SMA drugs, and that's really important to then feed into the databases and make sure we've got all the information going forward to the panels and to NICE to keep people on the treatment. So we'll complete lots of what we call outcome assessments. We'll look at how your hands are moving, what your arm strength is like, what your leg strength is like. Those who are walking, we'll ask you to do a timed walk. If you've got good movement, able to get on and off the bed, we might ask you to do different tasks like rolling on the bed, sitting up, standing down. Can you get off the floor? Can you do stairs or steps? So we'll take note of all those different kind of movements that you do and how well you do them. So that's a really important part. Not only are we kind of monitoring how you're doing on the medication and the drug, but also kind of keeping that information of how you're doing in yourself and are you maintaining your current abilities. It's also really important to have your breathing checked as well. So that's something that we do in our clinic. I'm just asking you to do a very quick breath into one of our breathing machines, and it'll give us an idea what your lung volume is like and how strong your cough is. So that's something that is really important to have checked in our SMA clinics. So we're there not only to keep monitor of how people are doing on these new treatments, but also definitely to give out our physio advice and to be there to do onward referrals or speak about exercise or the different types of activities people can do. What I've definitely noticed in our SMA clinic is things that we've kind of picked up as we've gone along or have been missed. So important to make sure you're definitely having your regular wheelchair reviews, assessments. I've seen some wheelchairs that definitely could do with tweaking or have too much duct tape on them in some parts. So just making sure that we're going back to our wheelchair centres and that, you know, we're helping patients, making sure they've got the right adaptations and the right seating if you are using wheelchairs. Especially, I do lots of referrals onto our colleagues in orthotics, so hand splints, foot splints, some casts for spines, things like that. So if you're in a wheelchair or if you're walking, you might benefit from having some sort of orthotic and splinting device, and it's often the physios who might pick up on that first and make the onward referral. And a big thing for me as well is making sure that we keep our movement in our arms and legs, that we're doing the right stretches, that patients know how to either stretch themselves or have carers or loved ones giving them a good stretch so we don't get contractures and tightness into the hands, arms, legs, round the back of knees. So definitely maintaining that muscle, what we call muscle range of movement, that joint range, and that's really important with helping reduce pain and also keeping your limbs moving, especially whilst we're on these treatments. We don't want them, your joints stiffening up and therefore restricting what your muscles could do on these new treatments.
Thanks, Kate. That's fantastic. And in terms of being able to kind of monitor a patient and track the progression and how their movement's working, I was struck by something Channa said, which was around I noticed the appearance of stability, and I'm guessing that during COVID and lockdown, when you weren't able to see patients face to face, that became quite hard to assess over a screen. How has that worked? And I guess before I open out to others, in terms of physio in particular, are you kind of continuing with some of the stuff that you had to do during COVID because some virtual appointments work, or are you trying to get back to face wherever possible?
So we were really lucky in Sheffield. All our SMA clinic appointments were kept face-to-face, and we had a really good supportive team of our managers, and we decided to keep them face-to-face, obviously with all the masking precautions and reduced visitors and things like that in at the hospital. But we felt, because they're on these new treatments and because we want to make sure our monitoring is really rigorous in Sheffield, we did see everybody face-to-face, so we didn't have that virtual problem. And all our patients were really happy to still come into the unit and see us face to face. I think where we're based felt quite safe and secure. So patients were really happy to still come in.
Well, I think Katie I think she just managed to get to the end before we lost her, but I think she's about to come back in. But Maria, sort of hearing out the Sheffield experience, which I'm presuming therefore means Channa was able to see people more face to face in other services. Up in Glasgow, did you have to find ways to kind of measure progression through virtual appointments?
Yeah, so we basically spent a short period of time where almost all patients were being spoken to over the phone. Or virtually over a video, but we then very quickly moved on. So if we consider the pandemic started end of March 2020, I think by the summer we started actually selecting a lot of patients that we thought we should really see face to face. But it was really a selection process, and I would say now that we're 2 years down the line, I would say 95% of patients are actually being seen face to face. By July 2020, we had decided that we should not really assess new patients virtually. That was a decision made quite early on, and it was felt that, you know, with neuromuscular patients, you really lose so much by not seeing them face to face. But the follow-ups have been kind of it's been a gradual process, I would say.
Great, thank you. Channa, you mentioned in the research section, actually, you mentioned, I think there was one trial in particular that you mentioned fatigue, and actually we had a question about managing fatigue. So it'd be interesting, away from looking at treatments, I'll come to you first, that's okay. Yeah, what do you offer advice and support for patients on how to kind of deal with fatigue? And is that a common issue for people living with SMA?
Thank you, Rob. I think that's a very important question. Fatigue is a big issue for SMA patients, and the lack of ability to measure it objectively is also a big issue. So we have been using some patient-reported outcome measures to measure fatigue in Sheffield, called the short questionnaire of PROMIS, where the patients are asked to score their level of fatigue, and this way we were able to also look at how the new drugs are affecting fatigue, and patients do report an improvement in fatigue with both with Risdiplam as well as Nusinerson in our cohort. In addition to the drugs, I draw my fatigue advice from patients that we manage with fibromyalgia or chronic fatigue syndrome. In those conditions, you're taught to pace yourself, and if you know certain activity, for example, I have a patient who works in the NHS, and when she walks from her car to her clinic, she wants about half an hour to an hour to relax and get her strength back. So we discussed about maybe you utilize a different method. Either you park closer, you obtain some permission, or you use a wheelchair to get your initial distance covered. But after that, your work within the ward setting, or if you go to a park, you might want to decide how you're going to get to the park. maybe you drive as close as possible, and then use your energy and strength levels to walk within the park and enjoy that. So pacing yourself, adjusting your life, and planning ahead are some of the advices that we discuss with the patients. And then also we discuss about dietary management and for example, trying your best to maintain your weight. For adults, some of the adult patients, gaining weight is a challenge, is an issue because of the physical weakness and the COVID restrictions meant that they couldn't venture outdoors very much, and that sort of caused gaining of weight for some patients. So therefore, getting in touch with the local dietitians and having a discussion about what measures they can do to change their dietary patterns have helped them to manage weight in order to help their fatigue levels, etc. And we also monitor what we call SMA safety bloods. We look at their calcium, thyroid functions, hemoglobin on a regular basis. We didn't used to do that, but now we do that. And then we found that a lot of patients have vitamin D deficiency. And some of the patients have also been found to have thyroid, underactive thyroid, and correcting these will also, I believe, will help their fatigue levels. So there are things that we can correctable medical causes like deficiencies in vitamins and thyroid dysfunction, etc. At the same time, learning to pace yourself are the ones that I advise.
Katie, Liz got a hand up. Just as about to ask you. I'll come to you first, and I'll go to Liz. But in terms of is that often a conversation you find yourself having with patients as a physio, in terms of encouraging people to pace themselves because they want to try and do more? Is that something that is fatigue something you help sort of people deal with?
Yeah, definitely. And it is a big factor with our SMA patients and a lot of the neuromuscular patients. I think going off what Channa has said, it is the pacing. It's trying to think about how you can adapt or change the activity. What I say to my patients is make sure you're using your energy for the things you enjoy, things that bring you that happiness. Is what's important. So if you have limited energy, make sure you're spending it wisely, rather than, trying to get somewhere or do something. There's always kind of a way around it, but make sure we're using our energy wisely and it's bringing us happiness. And whether that's going for a walk in the countryside, whether that's seeing family, whether that's going out to the cinema, it's really important that we kind of make the most of our fatigue and our energy levels, and we're getting the most out of our day to day, really.
Thanks, Katie. And Liz, did you want to come in?
Yeah, I was just interested, Channa, you were saying you're doing the SMA safety bloods. Are you seeing those results? Are you speculating that's linked with the SMA, or are these coincidental findings? It sounded very interesting.
I do not think that they're connected with any of the treatments that we are using. I think these are things that we should have picked up maybe 2 years ago, 3 years ago. We are picking them up because one of the great things about these two new drugs that I have seen is that not only in SMA, that these two drugs have changed the neuromuscular services in many centers, and we become aware of the need of seeing patients more regularly, and the fact that I drew from myotonic dystrophy patients about having their safety checks on a regular basis, and having using that same blueprint to the SMA patients meant that we were picking up things that could make a difference to those patients, like the vitamin D deficiency, thyroid dysfunction.
So more a general health check, because those people are coming to you. It's not necessarily their SMA, but it's actually we're picking up other aspects of health, perhaps.
Indeed. So, for example, when you're doing, we do a calcium check, calcium profile and a bone profile, and that is relevant to SMA because we know SMN gene has implications on calcium metabolism, and patients who are in prolonged wheelchair occupancy and who have had spinal surgeries, their bone health is at risk. So calcium assessments, vitamin D are a little bit more targeted than general health check. But even having this general SMA related check has not been done in the past for the majority of the patients. So increasing the minimum standard of care for the SMA patients have increased, in my opinion, in our center. So this is, I'm sure, across all other centers as well.
Thanks, both. That was fascinating. We've got a couple more questions to go, but there is time, I think, to cover some more. So do use the Q&A function if you'd like to get some more questions in. The next question actually spins out, I think, a bit from what Channa and Liz were discussing, and some stuff we've heard before, actually, around just the number of things that can be measured when treating adults with SMA. But just wondering, it'd be great, interested to hear, maybe go to Maria first, in terms of what decides what you record and measure for an adult with SMA, or how do you decide to what you kind of record?
That's thank you for that question. That's a very interesting question, actually. May I speak about the Scottish experience?
Yeah, of course.
So we don't have the managed access agreement in Scotland. So we were really sort of, we were left, to our devices to decide what we felt was important. And some of it was really adopted from the Newcastle, I suppose, practice. So we would have adopted the same physiotherapy assessments that that were recommended. But other things that we thought were important was actually trying to establish the bulbar functions, so the swallow and the speech and the voice aspect of the SMA involvement. So we often think about, the breathing muscles, we think about the arms, the legs, but the other aspect in SMA is actually the swallow that can be affected, chewing side of things, and the voice, the projection of the voice, which obviously, if you are, for instance, a teacher, a singer, that is going to be of a major impact. And Channa already has mentioned fatigue, and we actually use the same fatigue score that Channa has alluded to already. So we concentrated to a certain extent on the bulbar aspect by looking at a voice symptoms scale, and another scale that's called Dysphagia Handicap Index. And my patients hate it because of the word handicap, but I try to convince them that actually the items that make part of the scale are actually very important. And the fact that it has an amazing way of breaking it down, because there's a physical component, there's a emotional component, and a function component. So it's actually a very good scale. So we thought that would be very important to incorporate in our assessment. And then one of the other aspects that we actually decided to measure was actually jaw tightness, so the extent of mouth opening that these patients have. So as some of you would be aware, in SMA, the jaw can be very tight and very contracted, causing trismus, and some patients can be affected more than others. So we thought it would be important to assess that, because some of our patients have quite significant trismus. So we concentrated on those aspects, so the physio aspects, the energy, fatigue side of things, and the bulbar side of things. And we also measured a little bit pain and discomfort in order to be able to ascertain, after 6 months, 12 months, 24 months of treatment, is there actually a change in that, and trying to capture really change, because that's what we're trying to do with novel therapies, of course.
Great, thanks, Maria. And Katie, in terms of what on your side, sort of Channa talks about taking some sort of practice from other kind of disease areas. Is that similar in terms of there are some overarching principles of physiotherapy that would mean you'd record certain things, and how do you then decide what you might additionally sort of track in patients with SMA?
Yeah, definitely. There's elements that do overlap, or I think as a physio, there's sections that you would always look at more than others. So like I said before, definitely looking at how strong people are, their range in their arms and their legs. So can they move freely? Have they got any contractures or tightening around their joints? So that's something that we regularly monitor. and definitely look into making sure that our SMA patients who are in a wheelchair are sitting comfortably, have got the right equipment, have got the right equipment at home as well, and whether we need to get our OT colleagues in, our occupational therapy colleagues, making sure their slings at home haven't got holes in and things like that. We've discovered a few of those. And then for our patients who are walking, we definitely look at the falls element, and are they having falls? Is it regular? What's causing them? And some simple advice can be given physio-wise. Sometimes it's advice on walking aids. And like I said before, having a look at orthotic devices and whether they need something in their shoe or around their foot to help with that clearance. So those kind of elements do arch over lots of different neuromuscular conditions. And then, you know, kind of coming in more specific with our SMAs is patients do ask, you know, what exercises can they do, or you know, how to stay fit and healthy. And we do have some patients who use their local pools and enjoy, you know, go swimming if they can get in into the pool and if they've got good facilities. And that's something that can be really helpful and kind of give you that freedom of moving in water. One of the things we tend to kind of come away from is lifting heavy weights, just because of the excess stress over the muscles and the joints. So we wouldn't advocate lifting dumbbells or heavy weights like that. Often we can use the weight of our own arm or limb or leg to help, or sometimes using the stretchy TheraBands, the stretchy bands. But definitely, if you're going to start any exercise, I would speak to your local neuromuscular team, get specific advice and a specific program from your physiotherapist to make sure it's really tailored to you before you start doing anything, so we don't have any injuries or do anything that we shouldn't be. So your local physio would definitely be able to advise on a specific plan for you.
Thanks, Katie. We've had a question in from someone on the audience around psychological support, which I think is a really, really interesting question, a really sort of key area. I know that some services have access to specialist neuromuscular psychological support, but that's quite rare, and it's an area that MDUK is looking to kind of campaign for more provision in. But Channa, first I wonder, kind of in terms of being able to signpost patients to psychological support, what kind of advice are you able to give patients, and what kind of services are you able to provide for people or signpost to?
So thanks, Rob. That's a very, very important point. In fact, I was thinking of raising some of the concerns that I've had because most of the SMA patients who come to us come with someone accompanying them, either their parents, family, or a PA. And often, in addition to the measures required by managed access agreement, we also assess the quality of life assessments to understand, partly to advise the managed access process, but also to understand the impact on the patient's life. And in the discussions, when it comes to discussing about mood, there is always I've noticed in good proportion of patients that there is a difficulty in opening up about how the mood and the life in general is affecting their mental health, partly because sometimes they don't want to let the bystander or their family member down by admitting to any shall we say, pressures in mental health aspect, or if there's anything unhappy. It has been a bit difficult because a couple of times when I had want to have a personal conversation, it already then creates a friction, unspoken friction between the accompanying person, the patient, and myself. So you have to be very sensitive to approach this subject. In such situations, I have written to the GP separately with the patient's agreement that this patient might need a referral to a local counselor or a therapist, especially if they were traveling to our center from other towns. And a few of patients are actually very bright and they are already in university education. So I've written to their university medical department, the university GP, to help this young person access such help. In Sheffield, we have increased access to psychological therapies, IAP services, but as you know, it is not a tailor-made process. It's a general mental health support and well-being service. It's not really, in my opinion, very useful to. It's not very useful to the neuromuscular patient cohort. We don't have a specific help for neuromuscular patients who have psychological problems in Sheffield. As you know, over the last couple of years, we've been trying to set up funding for neuropsychological support in Sheffield. Various challenges have come, has made that plan quite delayed. So in essence, we do not have specific help to offer patients other than advising the GP and offering neuropsychotherapy type treatments. In Sheffield, the waiting time for that is over a year. So I know MDUK has had a telephone access helpline for counselling. I have not used that. If it is still available, then that might be an option for us. But certainly what I've noticed in summary is that there are mental health issues amongst the SMA cohort, which I have become more aware since I started seeing these patients more regularly, and because we have seen them more frequently, not just at 6-monthly intervals. Risdiplam patients, I've been following them up every 2 months through the EAM scheme, and Nusinerson patients, I've been seeing them pretty much at least every 3 to 4 months. So you begin to develop a relationship, and then they start opening up and sharing more information with you. So I think that this is an area that we need to work on.
Thanks, Channa. Yeah, sadly at the moment, MDUK isn't able to offer some counselling over the phone, but we can provide some signposting, and also we have a peer support service, so we can connect people to a peer support volunteer, which people find really valuable. Maria, I don't know if you want to add anything from what you're able to provide up in Glasgow, or broader thoughts on this.
Yeah, I echo Channa's concerns that patients, not only SMA, but all neuromuscular patients, have very little access to professionals that can help with counselling. What is available at the moment is really psychiatric services, which are not appropriate for patients for SMA or for any other neuromuscular patients. And what they require, in my opinion, is psychology services, counselling. And in some of our neuromuscular cohort, so for instance, in patients who have myotonic dystrophy or mitochondrial disorders, I think neuropsychology is actually a small niche that we should be able to tap into. But of course, all of these services are often oversubscribed and to a certain extent underfunded as well. But yes, I fully agree that our patients should be having full access really to some kind of counselling services, psychological support, and much wider access to psychology, I think. And
thank you. I'm sorry.
Tailored, I think, to that particular condition. I don't think all their needs are necessarily generic or the same. I think different conditions result in different requirements.
I think on that point, actually, something we found in our research is why we're kind of so committed to campaigning for specialist provision is exactly that, actually, that the frustration of people having to explain their condition to someone before they can then actually start having a conversation about the sort of the mental health impact it's having on them. So why that specialist knowledge is so important. Liz, you've got your hand up. It'd be great if you wanted to come in.
Yeah, I mean, just to say, completely endorsing what you're saying. You know, and all we can offer is some emotional support at the end of the phone, but it's really about signposting to specialist services And we've got a lot of those listed under our Living with SMA website, but we do find a lot of people are, they're forced to go privately, and it's so expensive, and they don't have the income to sustain that. So I think we're looking forward to working with you, MDUK, later in the year, when I know you want to really focus on this.
Thanks, Liz. That's great. We're into the last 5 minutes. We've got one more live question, which I fear is deceptively simple, but I'm going to see if Jana can answer this succinctly. Someone's asked, what is the difference between 5Q and non-5Q?
Yeah, so 5Q SMA is defined as those who have the mutations in SMN1, survival of motor neuron 1 gene, which is located in the chromosome 5 long arm. And non-5Q SMA are other conditions which cause spinal muscular atrophy, like phenotype. Phenotype means they develop the similar kind of muscle wasting, and the weakness associated with it are all similar. And not everyone who presents with muscle wasting and weakness have spinal muscular atrophy. But those who present with muscle wasting and weakness and bulbar or swallowing problems or breathing problems, then they get investigated to look for a cause. One of the causes is SMA due to SMN1 gene mutation. So that is 5Q SMA. And there are lots of other genes that can cause spinal muscular atrophy, like picture, and those are non-5Q SMA. So this difference is important, because if you're using certain treatments which target SMN1 related disease, such as the spinal muscular atrophy that we are talking about, then those treatments are not applicable to those people who do not have 5Q SMA.
Thanks, Tanner. Liz, you wanted to come in.
We do not give medical advice, and I am not suggesting we know anything clinically in the way that you do, but we have an area on our website which is rarer forms of SMA, which if people wanted to get a little bit of an idea of some of those very, very rare conditions, very little information about them, and it just gives you a glimpse of some of these symptoms that people with these very rare forms are having to manage.
Thanks, Liz. I'm going to squeeze one more question that we had in advance, because I think it's something that certainly I got asked a bit more as treatment started to become available for SMA, which was around adults who perhaps either never really been engaged with a specialist neuromuscular centre or had drifted away from one. Well, how could they become sort of re-engaged and see a specialist team? Is that through a GP referral? So Maria, I'll come to you first. And then in terms of accessing specialist physio, Katie, how would that happen? So yeah, Maria.
Yeah, so thanks for the question. I mean, we've seen this actually happening in the last few months, particularly because patients have become aware that new therapies are available, and therefore there is more of a reason to start engaging with the neuromuscular team. So I would say discussing first with the GP primary care, and then an onward referral to the neurology team. Sometimes these patients would have stopped engaging with the neurology team, but would have continued with respiratory support. So they would have continued to attend their clinics with the respiratory team. And sometimes the referrals have come through the respiratory team, where they have had discussions to make them aware that there are new therapies, and subsequently they have made referrals on to neurology. So there are different ways of coming back into the system.
Brilliant. And yeah, Katie, how would someone find their way to sort of specialist neuromuscular physiotherapy?
Yeah, through a really similar route, actually. So if patients get a referral in via GP or other consultant teams to their neurologist, so their neurologist will then be able to put them in contact with their specialist neuromuscular team if they're coming to a main centre hub. Definitely for us in Sheffield, if you're coming to the SMA clinic, so all our patients are now seen in SMA, whether they're on treatment or not, they're seen in our specialist clinic, and then you'd see myself or one of my physio team members, and we'll do a thorough assessment and sort out any problems, and we'll see from there. So yeah, definitely get in touch and get referred in.
Brilliant. Thanks, Katie. That unfortunately is the end of our session. So thank you so much to our panelists. I won't name you all because then I'll run over. So I'm delighted that I'm going to finish bang on time. But huge thanks. It makes such a big difference to be able to have such a wide range of expertise on the panel. And really thank you so much for giving up your time to be with us. And thank you for people who submitted questions. That's really helped the discussion flow as well. And also huge thanks to our sponsors for their support of the Muscle Matters series as well. So a quick reminder that you can see the recordings of the sessions on our website, and we'll make the recording of this session available over the next few days. And do get in touch with us if you have any questions that you weren't able to ask in this question, or if you've got anything that's been sparked by the discussion. So thank you very much for joining us. Enjoy the rest of your afternoon and take care, everybody. Thank you. Bye-bye.
Bye-bye.
Bye.